So when you look at the disease of token, let's call it tokenitis. So we have 3 forms of tokenitis. The first one, which we're going to look at here, is a Tokenitis duplicata. It means that the same patient has multiple patient IDs and they're overlap in the claims. The second tokenitis is Tokenitis splitica. So one patient gets 2 patient IDs and there's no overlap between their claims. And the third one is Tokenitis collisionica, where you have 2 patients that get mapped onto 1 patient ID, okay? So maybe next year I'll tell you about the other cool stuff I have, but today we're going to talk about duplicates.
I just want to say it's the coolest naming, right? So it's just fun to because it's like data, numbers, it's coding. So I'm just glad you named it such funny names. So thank you.
So we're going to talk about we call it the magnet algorithm, and that's the algorithm that's going to attract the duplicates that we're going to come together for us, right? So we've done work to merge databases, PLD databases, when they're tokenized differently, right? So you can picture all the major, well, it doesn't have to be major, by the way. Any PLD that you can think, open, closed, we don't care. We can match them based on the overlap of the claims. So in essence, it has to do with what is the probability that 2 patients, different patients, they have the same age, they have the same gender, they operate in the same geography. They went to see Dr. John Smith on the 7th of February, and they got those ICD codes. 1 week later, they got the same NDC code stuff, and 2 weeks later, they went to the hospital the same day, got out of the hospital. What is the probability of this happening? We can compute that probability, right? So we computed the probability of those overlapping claims, and then we have some kind of threshold and say, this is most unlikely to be due to fluke, right? Something may be happening there. So we did projects where we combined not 2 data sources, but we combined 4 data sources together. So we created like a dictionary. We have the Bayser ID, and then we have data source 1. This is how they call the patient. The data source 2. This is how they call the patient, and so on. And for many of them, we don't have all 4 of them because otherwise, why would you buy 4 data sources, right? You buy to have the increment, right? So for several of them, you have like 2 or 1, and some of them you have 4. And so around April of last year, I get that wonderful idea. And I said to myself, what if we match a database against itself? Right? So the JP, you're really stupid, man. Why would you ever do that? Why would you match it? Because we know there's a patient X that's going to match patient X. That happens in 93% of the cases. In 7% of the cases, patient X matches with X prime, X double prime, X triple prime. And in English, what it means, those are duplicates, right? That's how we identify duplicates without having PII, okay? So now we have different levels of confidence based on what we call the NLP. It's not a great choice for not natural language processing, but it's a negative log probability of this happening. It's like when you compute the pH of solution, it's like negative log probability, right? So we use the NLP as one of them, but then we look at different criteria. And so we can layer the levels of confidence that we have when we say that those guys are duplicates. So that's kind of the essence of how this thing works. And one thing that we need to manage when we do that is that we call it the cross. And basically when you get the patient X is going to match with the patient X with a certain probability, right? No, you're interested in the negative log, actually, of that probability. But it matches with a given probability, which is a function of the number of claims that overlap. And the rarity of some claims. If you go, it's a physician visit, this is very common, so you can't say too much. But if it is a very specific ICD code, this needs to carry some weight to it, right? So we factor all that, and the NDC code and has to do with the frequency of occurrence of the drugs and the procedures and that stuff. So we can compute what is the kind of the other suitors, if I can use that word, for patient X, right? So there would be a Y or X prime and so on. And that little chart on the what you have here captures this. So we analyze this to be able to say, okay, there's a challenger, but the challenger is serious enough that maybe I want to call it a duplicate, right? If it's not too strong, like I think the size of the bubble shows, it can give you an idea of how strong it is, then we say, oh, we're not very sure about